Hi, I'm Wendy Stock. I'm a professor of medicine at the University of Chicago, and I focus my clinical and research care on patients with acute leukemias, in particular ALL. And I am going to try to give a brief overview of my thoughts on asparaginase management in adults with ALL, which is a very challenging area that needs good prospective study, since we know that asparaginase, particularly for the young adult population, has made a very big impression on improving outcomes for these patients with ALL. And yet it's quite challenging to manage and dose asparaginase properly in these patients. There are no formal guidelines. There are many expert panels, etc. And ASH actually is about to issue, and I've been lucky to be a member of this guidelines committee, guidelines on treatment of young adults with ALL, some of which will deal with the issue of asparaginase management and dosing and toxicities. For me, I think that one of the questions that I've had in my mind for a long time is whether or not asparaginase dosing should be as intensive in terms of the actual dose in young adults with ALL. I think this is a drug that we can give to younger adults, but it has been extraordinarily challenging to give to older adults. And so for my younger adult population, the recent studies show that probably most young adults, but not all, can tolerate doses of 2,000 units per meter squared. What we are hoping to do, I think, is understand whether that dosing is appropriate, adequate, or too much. And one of the ways to do that is by doing therapeutic drug monitoring in patients with who are receiving asparaginase, which we do at our center. And in patients who are morbidly obese or who have other issues that relate to hepatic dysfunction or diabetes, we often start with a lower dose of asparaginase, but that hasn't been prospectively studied. It has been retrospectively studied, and it seems in most cases to achieve therapeutic levels and may, in fact, although this needs to be studied, as I said, prospectively, perhaps reduce some of the worrisome toxicities that we see with asparaginase. What are these toxicities? The toxicities include hepatic toxicity, transaminitis, hyperbilirubinemia. The more serious ones, of course, are thrombosis, particularly central nervous system, sagittal vein thromboses, pancreatitis. And for me, the questions surrounding the management or prevention, particularly of those toxicities, is one that also needs to be studied. In the United States right now, there's a prospective study of patients, children and adults receiving asparaginase-based regimens where the drug L-carnitine, which in a number of smaller studies has been shown to ameliorate or prevent hepatic toxicity, is being studied prospectively. The issue of anticoagulation is one that is a very important one, particularly during the first month or two of treatment, when the majority of serious thrombotic events occur. At the same time, we don't know for sure what or whether specific anticoagulation is appropriate. And for us, we have based our approach to anticoagulation mostly on monitoring of antithrombin levels, which hasn't in many studies been shown to be the best way to do things. And yet we don't really know. Other centers use prophylactic treatment during especially the induction months of therapy. So management of pancreatitis, that's a very serious toxicity. If true pancreatitis, serious pancreatitis occurs, those patients cannot be rechallenged with asparaginase. And one has to think about how to create alternative regimens that don't use asparaginase. And so that is another very difficult area that we don't have a perfect answer to. And it's very hard to predict who might get pancreatitis. In terms of how to try to manage any of these toxicities ahead of time, as I said, it's very difficult to prevent. because we don't know what causes these things or who is at particularly high risk. There have been some actually interesting studies moving forward now that are looking at risk factors for development of thrombotic events. And perhaps that population will be the population using these new models that are coming forward will be the ones where we can study very prospectively and very carefully the issue of anticoagulation. But again, at this moment, there are no formal guidelines for doing that, and more data are needed.